All right, welcome in everybody. It is Friday, and this is the first Friday of COPD Awareness Month. My name is Mike Hess, and this is COPD Navigator Live, presented by this month by the COPD Foundation. I am a respiratory therapist, and I am one of the state advocacy captains for the foundation here in the state of Michigan. Very gratified for the opportunity to be speaking with a lot of you today. For those of you who may not have seen these webinars before, our plan is to offer a little bit of news about what's new in the world of COPD. Then we have a half-hour topic, which today's topic is COPD basics, kind of a introduction to this disease that we all talk about and some of the basic facts behind it. And then we take some questions. So if you have any questions in mind regarding the basics of COPD, regarding medications, oxygen, please feel free to type them in the comment box under the video. And we will get to them as soon as possible and answer them in as in-depth as possible as we can in this format. Again, my name is Mike Hess, and I'm one of the state advocacy captains, and I highly recommend, if anybody is looking for a great opportunity to get involved with the foundation, to join the state advocacy captain program. We'll go ahead and throw a link right here, and there we go. You can head up to that link there and join the party, so to speak. You can learn a little bit more about who your state captains are, get some contact information for them to help participate in various activities, and join yourself if you're so inclined. One of the biggest things we do in advocacy is promote COPD Awareness Month. Every November is, of course, COPD Awareness Month, and then I believe it's the second Wednesday of every month this year, or every November. This year it's the 15th, is what we call World COPD Day, which is sponsored in part by the Global Initiative for Chronic Obstructive Lung Disease, or GOLD, which is kind of an international organization that tries to do a lot of research and put a lot of strategy recommendations out there for best practices and best treatment guidelines. So, of course, one of the things we like to talk about, again, with it being COPD Awareness Month, you'll hopefully be seeing a lot of these kind of proclamations going out in whatever state you happen to be on. This is ours from the state of Michigan. We had our governor was able to sign that, and we had November officially declared as COPD Awareness Month. We're looking to try to bring a lot more, use that as a tool to try to bring awareness and to launch a bunch of other activities to try and get people to understand exactly what COPD is and how we can do a better job of diagnosing it, preventing it, and managing it for those who have been diagnosed. But we'll get to some of that stuff more in a little bit of detail. I'll take a moment to say good morning to Sam and a couple of the other people who have joined in today. Gene, catching up on one of my lip sync for lung videos last year. Last year for COPD Awareness Month, I did a lip sync video. I played a song in the background, and I did a little dance and had some fun with that, and raised about $400 for the foundation. And some of those have been popping up again in as a Facebook guide. They've been popping up on my On This Day thing, so it's nice to see them popping around again. We had a couple of oxygen questions coming up here from nutrition. Welcome in Kathy and Nancy, and both Kathys there. Definitely we'll get to those later on today, but first I want to hit, as we like to do, and I say we, by what I mean by we is I actually administrate a group here on Facebook similar to the Foundation's COPD 360 site. It's called COPD Navigator, hence the COPD Navigator Live. And we do a lot of support and education, and that's where these videos started. I believe it was back about February. Had a lot of people asking very similar questions, and so we just decided to try to do this live interactive format and try to tackle everybody's questions at once, and it seems to have worked fairly well. And again, I appreciate the Foundation's willingness to put me on their page and get some stuff out there to a wider audience, hopefully. So, big news this week, a new study out in a journal by Dove Press, which is an open access thing, a little bit, it's still very well peer reviewed and that sort of thing, but a little bit easier to get published in, so to speak, has found that making sure that you're getting the right dietary nutrients in your diet can help preserve your lung function. Nutrition is unfortunately, and this will tie in well with what Nancy was asking. Nutrition is unfortunately very underrepresented in a lot of COPD management plans. It's not something we talk about a lot. Unfortunately, we see that even in general for healthy people, normal people, we also don't see a lot of conversation about what is good nutrition and good health. And so we're trying to do a better job at that, and this study kind of goes along with that. It took place in New Mexico and found that in their COPD population, if you were getting the right amount of nutrients, vitamins, and minerals like magnesium, folate, stuff we know that is helpful for good health in general, plus some things that we have suspected in the past might help with lung disease like vitamin A and vitamin D, making sure you get those levels kind of helps preserve some of that lung function. A lot of times we see in COPD your lung function will decline over time, but if you're getting the optimal nutrition, then you can actually slow down some of that rate of decline and add some life to your years, so to speak. There's not a lot of good data out there right now that's telling us that if you have higher than normal levels, that will prevent exacerbations or things like that. But a lot of people have lower than the acceptable amount or the recommended amount of these nutrients. And so this is just another study that is very emphasizes the critical nature of getting good nutrition, especially when you have chronic lung disease. Next up is actually a news item featuring the COPD Foundation, which is joining with a tech company called Javion. I think is how you pronounce that. Another large hospital system in Pennsylvania called Geisinger Health System, and the drug company GSK to create what they call a cognitive machine learning program that is designed to avoid hospital admissions and readmissions in COPD. And this is kind of a really interesting thing. It's almost like artificial intelligence looking at all these data points out there, trying to compare people, look for common factors, and try to match them up with therapies that are going to optimize their health. If these are people who have just gone into the hospital, these are ways to prevent them from going back into the hospital. And it'll even supposedly go so far as to match people up with appropriate clinical trials that might optimize their lung health. So it's a very exciting initiative. It's very early on, but it's going to be very cool to see what technology can do to try to improve quality of life for a lot of people, and if nothing else, keep people out of the hospital. Last up this week is news out of the medication world, which is kind of exciting. Two nebulized, what we call long-acting muscarinic antagonists, or LAMAs. Many of you are probably, hopefully, familiar with a drug called Spiriva, or there's also Tudorza, Incruz. These are all acting on a chemical pathway to help, that has been shown to work very well in COPD, as opposed to some of the, well, it's even increasingly acceptable in asthma. But this drug class has really only been available in inhalers, whether it's a dry powder inhaler like Tudorza and Incruz, whether it's one of those newer soft mist inhalers like the new kind of Spiriva that's out there. But these two new medications, one of them is called revefenacin, and one is called glycopyrrolate, have both passed FDA phase 3 trials in nebulizers. So these are things that might be available for those people who are not able to use, or not would prefer not to use a standard inhaler, and are more comfortable with a nebulizer. The traditional breathing treatment, so to speak. It's exciting because while glycopyrrolate's been around for a little while and is actually in one of the combination meds right now called Levespi, revefenacin is new in the pipeline, and they're both exciting because it's nice to have options. You know, we in my personal opinion, this might sound a little bit soapboxy, but we in medicine tend to forget to take into account people's needs and preferences sometimes when we're recommending or prescribing a medication. And some people are not able to take a dry powder inhaler very well for a lot of reasons. But for those people, we haven't had a really good solution where we can match up their needs of a medication with their abilities in taking the inhaler. And so if we can have some of these new drugs come on the market and make sure that they're accessible to a lot of people on formularies and not devastatingly expensive, then it's nice to have some more ammunition, so to speak. So that is kind of our big news items for the week, and now we get into our regularly scheduled topic. I'm glad to see there are a couple of questions still piling in, but make sure that if you have anything on your mind, whether it's on our topic of the day, whether it's one of those news items, or whether it's just a general question, please feel free to get those in so that we can get those after we get through our lesson plan for the day. So the big question as we get into COPD Awareness Month is what exactly is COPD? And there's been a lot of debate over that over the years. COPD is a term that kind of came into what we would consider modern use back in the 60s. And basically back then we had two main forms of this disease. We had chronic bronchitis, where you have this all the time overproduction of mucus. You have trouble coughing it up. Sometimes it's very thick. Sometimes it's just so much volume that you can't clear it out all the way. And then we also had emphysema, where you might not have so much in the way of mucus, but you had these big giant lungs as some of the air sacs kind of broke down a little bit, and it was tough to get air in and out like that. Let me catch up with Kathy's question there. That is revefenacin and glycopyrrolate. So here's an excellent slide that I saw this summer at a conference called COPD 10 USA, which the foundation put on and is one of the leading conferences specifically for COPD, where we bring together all the disciplines that are involved, respiratory therapists, physicians, pulmonologists, everybody on the table, nurses, and including people living with COPD and their caregivers, which is critically important in my opinion. So we have this slide from them that kind of represents a little bit of what I'm talking about here. How does COPD exactly affect your breathing? We see in normal lungs over here, you have these little air sacs that kind of look like bunches of grapes, and those are called your alveoli. And what happens is that the air comes in, you breathe the air in, it goes down into your airways, and this is where the gas exchange takes place. The good air, the oxygen goes in and distributes out into the bloodstream, and then you exhale carbon dioxide, that all comes back out of there. Well, when you start having lung damage, you have, again, these two main forms of damage. You have bronchitis, where you get a lot of mucus building up in there. The alveoli, they're usually kind of okay, but you have a lot of this, you have a lot of inflammation, a lot of swelling, a lot of this mucus production kind of going haywire in bronchitis. And then you have emphysema, where instead of looking like little bunches of grapes, these kind of turn into bigger balloons, and that can cause several different issues, especially in that your lungs are designed to be stretchy, like a latex balloon, like an old school latex balloon. And if you can think about that, if you blow up a balloon, it kind of stretches out, and then as soon as you stop blowing out, it wants to recoil and push all the bad air back out. Your lungs want to do that same thing. But when they lose the stretchiness, then it's more like trying to blow air into like a hefty bag, where you don't have that recoil and it's a lot harder to get that air out. Plus we see some of those, the very fine, these very small airways can collapse down. They lose some of their muscle tone. And they collapse down and trap a lot of that air in. And when you've got stale air trapped in there, it's a lot harder to get the fresh stuff in on your next breath. It's like trying to fill up a glass that's already full. And so then you get short of breath because you can't get that stale air out, and then you run into all kinds of problems. We have also found more recently that there are a couple of other things that fall under this COPD umbrella. Most specifically, some forms of asthma that are severe enough that even when you have your bronchodilators and stuff like that, you don't quite get back to that normal baseline of lung function. And also a disorder called bronchiectasis, which is kind of like bronchitis, but you start seeing a lot more thickening of those airways. Sometimes you get this kind of chronic infection, and you can have pockets, and it's kind of a mess. But a lot of mucus in there, a lot of pus, and that sort of thing. These changes in definition have kind of led to some difficulties in getting people diagnosed sometimes. There are about 30 million people, we figure, based on various statistics, that walk around every day with symptoms that are associated with COPD, the breathlessness, the excess coughing, and all that sort of thing. But only about half of those people, only about 15 million, actually carry the COPD diagnosis and are therefore getting the appropriate treatment. And so that brings up the question is how exactly do we figure out, how do we diagnose COPD? How do we figure out what kind of lung disease you have? Because there are several different kinds of lung diseases. I've already mentioned two of them, asthma and COPD. There's also things like idiopathic pulmonary fibrosis and a host of other diseases that can present similarly. When you go to your doctor with shortness, or your provider with shortness of breath, it can be one of a dozen different things. And so one of the most important things to do is this test called spirometry, where you basically what happens is you blow through a tube and then you inhale through the tube so that we can see exactly how much air is getting out, and especially how much air is getting out in that first second. Remember I told you when you have COPD, sometimes you lose some of that elastic part, that rebound, and that slows down the speed of your exhalation, and that's what we call an obstruction. That's where the O comes from in COPD. And so we do this test called spirometry. You blow through the tube and you get this graph here where you see this person was able to blow out, and then you get a lot out in that first second or so, and then it kind of tails off a lot, and then eventually you can inhale. And this is one of my actual COPD patients. That's why I'm holding it kind of funny so you can't see any of their identifying information. But this is a very classic sign, or classic spirogram we call it, for COPD. We look at some of the numbers involved, and we look at some of the ratios, and we can look at the shape of that curve, and that's the true definition of how we figure out what is an obstructive disorder based on some of the other things which are called restrictive disorders. If you have things like a fibrosis, or what's sometimes called an interstitial lung disease, your lungs kind of get stiff, and you have reductions in their volume, and you don't blow out as much and all that, but the ratios are maintained. And so another thing that we do, especially more, it's increasingly common lately in the last few years, especially once that GOLD organization that I mentioned a little bit earlier changed some of their classifications, which we'll get to in a minute, is a symptom assessment test. This particular one is one that I use very frequently and is part of a guide, what's called the Pocket Clinician Guide, that the foundation puts out. I use this test on a daily basis when I'm talking with my patients, because while spirometry is great for diagnosis, it doesn't always correlate very well to how you feel. It doesn't always match up well with your symptoms, your exercise tolerance, all that kind of stuff. And that's where this test comes in. This is an 8-question survey that talks about how often you cough, how much mucus or phlegm or junk is in your chest, whether your chest feels tight, how you sleep, a couple other factors like that. And based on those scores, we can kind of get a better example of where your disease process is and how severe it is. That kind of segues me into the next thing, is people oftentimes ask, how do I know what stage I'm at? Or my doctor told me I'm at this stage or that stage. What does that mean? How do I figure out what that means? And that has also been a controversial topic and has only gotten more so over the last few years. When GOLD first started back in the early 2000s, right around the turn of the century, the science told us that your symptoms are going to be directly related to your airflow obstruction that first second, something we call FEV1, how much air you can blow out in that first second of blowing out. And the more that was reduced based on the predicted value, based on your height and your age and your gender and your ethnicity, that was going to be directly related to how bad your lungs were, and how much time you had to live, and so on and so forth. As time has gone on, and as we have looked at the science a little bit better, we've seen that doesn't really correlate as well as we once thought. And so just last November, just in time for the last World COPD Day, GOLD came out with what they call their revised assessment tool, which looks more at your history of exacerbations, how many symptom flares you've had, particularly that require hospitalization, and looked at that and along with your symptom burden. We like to use the CAT. There's also another scale called the Modified Medical Research Council Breathlessness Scale, which is also on the pocket guide here. But either way, that tells us whether you have you basically broke it down into whether you have a high symptom burden or a low symptom burden, and whether you're at high risk for more exacerbations or low risk for exacerbations. And that's where this severity guideline is going now. And so when people ask what stage am I at, or my doctor told me I'm stage 4, or hopefully nobody ever hears this anymore, I'm end stage, we're really trying to get away from that, because that's just a silly phrase. We're really trying to look at how much of an impact this stuff has on people's lives, rather than just the objective airflow number. Because that's where things like if you have a higher symptom burden, then you're probably not going to be able to exercise as well, and maybe you're even at higher. You would benefit even more from pulmonary rehab or some kind of other exercise program or things like that. And so it's very important that when we're talking about diagnosis and staging and all that stuff, we have a practical view about it, and we're not getting caught up on some of the raw numbers and putting everybody into a stage. Because in my opinion, and again, we'll get a little soapboxy, it doesn't really do anybody any good. It doesn't really improve what we do for our recommendations. It doesn't really improve your quality of life all that well, or any of those things. So if we get into the more practical, functional parts of things, then I think we can make a bigger difference. And that is important because it's important to remember that we want to keep an eye on that staging, because we see here from another slide from COPD 10 this year, if the more exacerbations you have, the more likely your lung function is to go down. This chart was originally based on a study that was done in the late 70s, and came up with a graph called the Fletcher-Peto curve, which is really great to use because it's also great for smoking cessation. Because we found that everybody loses some of your lung function as you get older, which kind of makes sense, because as you get older, your lungs don't work as well, your eyes don't work as well, your knees don't work as well, all that stuff kind of tails off a little bit. But if you smoke, it goes down a lot faster, as you can see on this line here. These dotted lines represent the idea that if you quit, your lung function change goes back to the age-related curve. A lot of these curves are found online. We'll try to get some links up as we get through here. But you can find a lot of these charts online if you search for like gold criteria or things like that. Or again, we'll be trying to get some of these links posted at the end of the video so that everybody can kind of have an idea of what to look at with that stuff. So, but bottom line is, the more exacerbations you have, the more likely you are to have declines in your lung function. That's why we work very hard to try to prevent those exacerbations and to try to get people back on the straight and narrow. And Catherine throws this out there right now, and bear in mind I will get to everybody's questions, but this one is particularly relevant right now. What happens when you have an exacerbation? And that's somewhat hard to say. Everybody's exacerbation is slightly different. The technical definition of an exacerbation is any elevation in your symptoms beyond your day-to-day normal. For some people, that looks like coughing up a lot more stuff. For some people, that looks like just being more short of breath. And it's sometimes difficult to tell because there's a lot of day-to-day variation. It's a little bit hard to tell how much of it is just having a bad day and how much of it is a true exacerbation. So there's some question about what exactly is an exacerbation. And it's very dependent on person to person. That's why it's very important to work with your clinician, your provider, to make sure that you understand what your day-to-day symptoms are, what we call our baseline symptoms, or what you experience every day. And then when you start having changes on that, making sure that things get caught early. Dr. Brian Type, who is one of our cornerstones, our Mount Rushmore people of COPD, talks about exacerbations being a lot like forest fires, where if you can catch them early, you can put them out right away and go back about your business. But if you let them grow and spread, then we're really looking at a big day, or a bad day, excuse me. And everybody has different triggers, like Susan points out here: cleaning products, wood smoke, tobacco smoke. That's why one of the most important things you can do to help your lungs is quitting smoking if you still happen to be using that. And we'll definitely be talking about that in one of these later sessions coming up here. The other thing that's kind of a downer that I want to touch on real quick is we're at the place we are with COPD because it has for a very long time been kind of an obscure disease. There's been a lot of stigma attached to it. Unfortunately, I've heard many stories about people whose provider has told them that, well, you should have known this was coming, you should have known better, you should have quit smoking a long time ago, you were a smoker, this is, what did you expect would happen? People kind of implying that people with COPD often deserved what they got. But we have, as more research has gone on, obviously we've found that that's not really the case. While tobacco smoke is one of the biggest causes of COPD, somewhere between 20 and 25% of those people with the diagnosis have never smoked a single cigarette in their life. We're also finding that there are a lot of environmental causes for it. If you live in a high pollution area, if you burn a lot of wood smoke, if you lived in a house that used a wood burning stove or that sort of thing. And of course, one of the main non-smoking causes, and I think Gene pointed this out, is a disorder called alpha-1 antitrypsin deficiency, where your lungs don't actually produce enough of a certain enzyme that counteracts part of the immune system, and your lungs are actually kind of broken down from the inside. And unfortunately, we see that this is remarkably underdiagnosed, even in terms of COPD. We figure that about 1 in 10 people who actually have a deficiency are diagnosed. So 90% of the people out there have lung disorder, shortness of breath, all that kind of stuff. Don't know why, they are clueless to figure out why, and are not getting optimal management. Because when you have something like alpha-1, you really need to we're able to supplement that enzyme and slow down some of that damage. And bronchodilators and stuff just aren't going to hack it in that environment. So speaking of research, we have found that unfortunately COPD does not get the kind of research funding that a lot of other diseases do. COPD is the third leading cause of death in the U.S. and actually around the world, but lags pretty far behind other diseases that are certainly worthy of attention, but don't necessarily have the mortality impact or even the impact on quality of life that COPD does. COPD is something that, and I'm sure I'm speaking to the choir here, affects pretty much every moment of your waking life and a lot of your sleeping moments too. This is something that changes the way it changes your entire lifestyle and changes everything that you do. But fortunately, we're seeing, again, we're taking a little bit more of a proactive view on a lot of this stuff through initiatives like COPD Awareness Month, but also through things like the COPD National Action Plan. This was an initiative that, believe it or not, was asked for by Congress. They asked the National Institutes of Health to start looking at how we can do a better job with COPD care. And I was fortunate enough to be a part of that initial working group that happened about a year and a half ago, where we had a whole bunch of people from a whole bunch of different stakeholder groups, including the COPD Foundation, including other respiratory therapy friends of mine. We even had Ted Koppel. If you were around in the 80s, it was kind of a big deal. I have a picture of me actually meeting Ted at this meeting because his wife, Grace Ann Dorney Koppel, has COPD herself and has been very active, led the COPD Foundation for a while, has been very active in trying to raise awareness and again do a better job at figuring out how we're doing COPD care in the U.S. And so we had about a year of discussion and debate and input and public input and back and forth and all that stuff. And this past spring at the American Thoracic Society's annual conference, they were able to release the final draft of the COPD National Action Plan, which again you can read for yourself at copd.nih.gov. It's a great document. It's actually written pretty legibly. It's not all the medicalese that we like to throw around. And it talks a lot about things that we're anticipating doing over the next few years to try and improve our research, try to stimulate more research funding, try to create better pathways between different clinicians, and improve the way we're doing things in general. Pamela, I do want to jump in there too real quick. Yes, this should be available on the Foundation's page as a Facebook Live. And then another tradition of mine is I do record these and I polish them up a little bit, put some links on there, and then post them to YouTube. So if you can go to youtube.com and search for COPD Navigator, you should be able to find these. Usually it takes a couple of days to get these up online, but you can look at some of our old episodes and check those out as well. And also, Catherine, I didn't mean to overlook you there. Pellet stoves can have anything that's burning can have some effect. Anytime you're taking in any kind of smoke, and more we're seeing even vape, the e-cigarettes, the vape pens, that sort of thing. Those definitely can have an impact on your breathing and your work of breathing. So, when we're talking about National Action Plan, we're talking about how we're improving COPD care. So what are our cornerstones of COPD care? Some of these things we'll be getting more into throughout the rest of the month. I gotta leave you I'll leave you on a little cliffhanger there to bring you back for next week. But of course, one of the keystones of COPD care is medications. Just about everybody who has COPD is on at least one kind of inhaler or nebulized medication. Hopefully you're on a good controller medication and then some stuff for rescue when you have those breakthrough symptoms. But it's very important to talk with your provider, whether it's a physician, nurse practitioner, a physician assistant, whoever it is, to make sure that you're on a plan that works for you. It's very important to be very straightforward and say, I don't like to take this medication. I've had people come to me and say, I haven't been taking it because I don't like the way it tastes. I can't afford it. And it's difficult to say, but that does happen. There are a lot of different things out there that we can change a medication to in a different format. A lot of times, we can find an assistance program. We can work with a lot of different people to try to get you on a medication regimen that is going to work for you and for us. I always tell people that my job is to listen to you and give you my best advice, and then your job is to follow your plan. It's difficult sometimes to execute all that. I'm on some chronic medications myself, and I'm not always the best patient with that sort of thing, but it's very important to try to keep as close as you can, to adhere as closely as you can to these plans. The next biggest thing that goes often criminally overlooked is a program called pulmonary rehabilitation, or pulmonary rehab. And basically what pulmonary rehab does is it's kind of monitored exercise, where you do some exercise, your oxygen level is being monitored, your heart rate is being monitored, all that kind of stuff, so that you're not at risk, but you can start building up your tolerance and getting back into shape, so to speak. In addition, the best pulmonary rehab programs also have a major educational component where they teach people about how to eat right, how to take your medications, how to recognize symptoms, all that kind of stuff. But unfortunately, we see that those aren't accessible to a lot of people. First off, because a lot of clinicians don't seem to realize they exist, and so they forget to refer people. And secondly, a lot of programs have had to close over the last few years because funding has been very inconsistent with pulmonary rehabilitation. That is definitely one of the main goals that was brought up in virtually the entirety of the COPD town hall that came up with the National Action Plan. And so we're really looking at different ways we can encourage pulmonary rehab over the next few years. Right behind pulmonary rehab is tobacco cessation. And that's another one that's coming up in a future episode. We'll touch on that briefly here. It's one of the best things you can do, but I also recognize it's one of the hardest things that you can do. Unfortunately, we have often looked at tobacco cessation as, well, why don't you just quit? But then we see that people trying to just quit, cold turkey, so to speak, usually have about a 90% failure rate. And so we're not doing a good job at trying to support people who are trying to quit and trying to make that improvement, because we're in my opinion, and something I'm trying to fix in my practice, we don't cover a lot of the psychological stuff that goes around smoking, the habits and the rituals and all that kind of stuff. But any kind of encouragement I can offer, and again, we'll definitely be getting into more effective strategies later on. I definitely want to try to quit smoking as soon as possible. Last couple of things, another major one, especially for more severe cases of COPD, is oxygen. Oxygen has also been under attack a little bit the last few years as funding has, Medicare funding has gone under a lot of changes, and they haven't always been, these changes haven't always been aligned with reality, we'll say. And so that has led to a lot of our medical equipment providers cutting services and reducing the kind of things that are available for people, which has a ripple effect in it reduces people's mobility, and you can't exercise if you're not mobile, and you can't be mobile if you don't have oxygen, and so you just kind of sit on the couch and go in the downward spiral instead of building yourself back up. But there are a lot of ways, if you are prescribed oxygen, I encourage everybody to wear it. I know that it's not comfortable. I know that it's not fashionable all the time, but it will improve your life to a remarkable degree. I've seen it happen many, many times. And so I encourage you to, if you feel that you're short of breath all the time, even with you're getting optimal medication management, you're doing all the things that you're supposed to do, ask your doctor for to do a pulse ox test with you for about 6 minutes as you're walking around the clinic and that sort of thing. And if your oxygen drops below 88%, then you qualify for oxygen, and you should probably get that. If you do have trouble getting your oxygen covered for any reason, or if you're having trouble with your provider, the foundation, the COPD Foundation, does have some excellent programs available to help advocate for you and to give you some strategies to help you get that accomplished. And so the last thing I'm going to touch on here is when the National Action Plan was released. One of the things that Dr. Byron Tomashow, who is the chair of the board of directors of the COPD Foundation, said that has really stuck with me throughout this all summer, obviously, is that COPD is a disease that has to live in primary care. Too many times, because of whether it's a failure of diagnosis or a failure of whatever, we're seeing that people aren't getting the care they need until they get to the emergency room or admitted to the hospital. In the best cases right now, we're seeing people who are well managed by a pulmonologist, but we also see that they can be difficult to get into, and they can have a lot of other complications there. So we really need to push harder for primary care, basically. And that's kind of where I come in. That's one of my pet projects right now. I am one of the rare respiratory therapists who works in a primary care office, because part of the reason primary care is not well equipped to handle people with COPD is because they don't have the time. Your average primary care visit is about 16 minutes long and covers about 5 or 6 topics. And so it's very difficult to cover all the complexities that we talk about in COPD in that kind of time frame. And so I'm trying to push for better access to respiratory care services in primary care. And hopefully we're going to be able to start changing that game a little bit, and getting people the care that they need, at the time that they need, in the way that they need, so that we can all start doing a better job at managing the stuff as we go on. So, and to that end, I actually have this on my wall right above where my COPD Awareness Month proclamation is. I have this oar that says "Row the Boat." I work here at right up the street from Western Michigan University, and we had a football coach up until last year who that was kind of his big strategy, his mantra was "row the boat," because I look at it as we're all in a boat together. It's me, it's you, the person I'm helping to care for, it's your caregivers, your family, your primary care provider, your pulmonologist, nursing staff, pharmacists. We're all in a boat together. And if we don't talk to each other, and we don't have open communication, and we're not honest with each other, there's no way we can coordinate what we're doing, and at best we're going to row our little boat around in a circle. More likely we're going to flip it over, and then we're all kind of messed up. But if we trust each other and we're open with each other and we have the knowledge and we share our knowledge with each other, then we can actually coordinate our efforts and we can row from point A to point B. So that's kind of the strategy that guides my practice, and that's what I'm hoping to bring all of you out here today. And of course, every week we do these Navigator Live events. I'm a big believer in the idea that an informed patient is an engaged patient. I believe that in my own life. I believe that with the people I care for. And so I try to spread as much knowledge as I can because that is one of the foundations of good care, in my opinion. So, I know that was a lot of information to throw at you in a half hour, 40 minutes there, but that's how we roll on COPD Navigator Live. And now is your time. Now is time for questions and answers. It'll take me a minute to scroll back up here. I know there's a lot of stuff that has come down the pipe, and I want to try to get this in here. One of the first questions was, please explain the difference between shortness of breath and the need for oxygen. They're separate, and a lot of folks get confused. And that is very true. Shortness of breath is a very subjective feeling. A lot of you may be familiar with when you go to your provider's office, you see that little pain scale. It's got 0 to 10, and then it's got the happy face, and the not so happy face, and the sad face, and the screaming face, and all that. The pain scale. Shortness of breath to me is very similar to that, and in fact there are a couple of scales out there that kind of represent that. Just like one person's 10 out of 10 pain might be somebody else's 5, shortness of breath is very subjective based on how you feel. When somebody with perfectly healthy lungs goes for a run or sprints their maximum effort, they get short of breath. The biggest difference between that kind of shortness of breath and COPD shortness of breath is that COPD shortness of breath is kind of ongoing all the time. Another factor that we talk about when we're looking at COPD is your oxygen saturation. Remember, I told you if it's 88 or lower, then you should probably get some of that supplemental oxygen. Unfortunately, lack of oxygen is not always the trigger for your shortness of breath. Just like somebody, again, with healthy lungs doing a wind sprint is probably going to be short of breath, but is probably still going to be moving oxygen in and out enough so that their saturation stays high. You, as a person living with COPD, you might not have any drops and you might not have any difficulty diffusing your oxygen in and out of your lungs, but you just can't move enough air in and out fast enough. When we exhale, a huge percentage of what we exhale is still just oxygen. There's a lot that just kind of sits in there without going into the bloodstream. And so even the stale air, oxygen can continue to diffuse in and out even if it's trapped in there. And so it's a very complicated, it's very difficult for a lot of people to get that shortness of breath isn't always correlated with that oxygen level. I try to look at it also as when I was in respiratory school, one of my instructors told me that your blood is kind of like a series of boxcars, and their cargo is oxygen, and so everything gets loaded up in the lungs and then gets shipped out to where it needs to be delivered. And so if you don't have enough boxcars, like if you have anemia, you don't have enough of those red blood cells, then you can have low oxygen delivery. And if your boxcars aren't full, then you have low oxygen delivery and you can get short of breath, and so on and so forth. Pulse oximeter only measures how full your boxcars are. It doesn't measure how many of them there are. It doesn't measure how fast they're moving, and so it only looks at one aspect of the overall oxygen delivery. And if any of those other aspects are messed up, then you can still have not enough oxygen, but still have a good saturation. And so that can also lead to shortness of breath. So it's a complex set of things that are working together to create shortness of breath or create that sensation, and then to fix the shortness of breath that aren't always related to that oxygen level. And so let's see, trying to scroll back up a little bit here. Let's see. Gene mentions find it really hard to get the dry powder in, and that is an issue that we see a lot with some of the more severe forms of COPD, the more severe categories, boxes. And that's why sometimes we're doing people a disservice and why it's so exciting to have those new medications that are coming out in other formats. We need to make sure that when we prescribe a medication, we need to make sure that you're actually able to take that medication. We do a great job at telling people to take drugs, but we don't always do a great job at telling people how to take drugs. And this is going to be our key topic next week, next Friday at 1 o'clock. We're going to be talking about the various medications and the various formats of medications that we use in COPD. But suffice it to say, we need to do a better job at trying to make sure that you're getting your proper dose of medication. Otherwise, you're just paying for something that isn't really working. So you are not alone in that. It's hard to get that stuff in sometimes, but we are working on it. So Michael asks, how do we know what stage we are in, and how can we tell when we go from one to another with COPD? Well, again, we'll fire up this chart again. This is what I like to use for staging. Traditionally, the stage has been the degree of your lung impairment, your FEV1. If it's less than 80%, then you're stage 2. If it's less than, I think, 30%, then you're stage 4, and so on and so forth. But again, that doesn't really mean a whole lot at the individual level. And so what GOLD, the Global Initiative for Chronic Obstructive Lung Disease, did was they looked at your history. How many exacerbations did you have in the last year? And they put it over here. If you've had 0 or 1 that didn't require a hospitalization, that's pretty good. You're at low risk. If you've had 2 or more, or if you've had at least 1 that sent you to the hospital, then you are at high risk for having another one. Statistically, the more exacerbations you have, the more likely you are to have another one. Now, along this line is the symptom impact scores. That CAT score, if it's less than 10, then you have relatively low impact. If it's higher than 10, then you have relatively high impact. And so that's where we start seeing these severity assessments come into play. And that's how you can move from one to another. If you've had 2 exacerbations in 1 year, maybe you're in this group C here. But then the next year, you're doing pretty well, you're much better controlled, and maybe you start moving into the lower risk area. And so there are a couple of different strategies. That's the one that I prefer. That's the one I think is most beneficial, most accurate, most practical. And that's how you go back and forth between the two. Deb mentioned on 3.5 liters of oxygen, why am I still so out of breath? Well, again, that kind of comes back to the amount of oxygen in the boxcar. Filling up the boxcars is only one part of the shortness of breath equation. You can still have high levels of carbon dioxide, and that might make you feel short of breath. You might still have a lot of air trapped in your lungs when you exhale because of the emphysema type of damage. One way to try to remove some of that shortness of breath is a thing called pursed lip breathing. It's very simple to do. You don't need any kind of special tools or special training or anything like that. All you do is take a breath in, put your lips together like you're about to whistle, and blow out like you're trying to cool off a spoonful of soup. That helps keep some of those smaller airways open a little bit longer and flush out some of that stale air. And when you do that, sometimes you can relieve some of that pressure and flush out, like I said, some of that stale air. I want to scroll back just a second here on a different page. We're getting a lot of questions, so I'm trying to make sure I cover as many people as we can here. All right, well, we're going to try and get, if I don't catch your question, I do apologize. Some of the quirks of Facebook scroll things out of sight before I get a chance to see them very well. But definitely we'll try to catch them. If we don't catch them now, we'll catch them next time. So let's see. Karen mentions emphysema, only 17% lung function, 6 liters of oxygen. That is a little bit of a pet peeve of mine when clinicians tell you have X percent of lung function. That is, in my opinion, a fairly meaningless designation, because your lungs have a whole bunch of functions, and when we do a proper pulmonary function test, we see that there are different percentages for different things. There's a different amount that where the oxygen goes across across into the bloodstream. There's volume. There's how much air you can blow out. And so when you tell somebody that they have a certain percentage of lung function, it doesn't mean anything because it's trying to break a number down way too simply. And so that's again why I'm glad that a lot of our clinicians are getting away from some of that stuff and more towards some of the symptom impact or exercise burden, stuff like that. Bonnie, hey Bonnie, based on the chart you showed, what does it look like if you have chronic bronchitis, emphysema, bronchiectasis, chronic respiratory failure? Well, it looks like you have a pretty long chart, if you'll excuse a little bit of medical humor here. But it's hard to pick out those diseases specifically on the basis of any of our charts, whether it's a CAT score or whether it's I think this was the chart that Bonnie was talking about. It's really hard to pick out a particular disease based on that. A lot of times when we're trying to lock down a little bit more what type or what we call a phenotype of COPD a person has, we look at things like their overall symptoms. We look at a lot of imaging. We look at CTs and x-rays and stuff like that, particularly when we start looking at things like bronchiectasis and emphysema that are more of a structural change in the lungs rather than just the mucus being overproduced. Those are kind of the things we look for when we see when we're trying to separate those things out there. Did I see the wing device? Kathy asks. I have seen. I think it's got a lot of potential. I'm reserving judgment to a degree until I see it a little bit more use. I'm an evidence guy. I like to wait until we've got good evidence for a thing before I do a lot of changing. There are some exceptions to that, of course, but I have seen it. I think it's got a lot of potential. The wing is a small portable home spirometer that can kind of keep an eye on some of your symptoms from day to day and help you pick out some of those early signs of exacerbation. Like I said, I think it's got a lot of promise, and I'm looking forward to seeing how the technology evolves a little bit. There's a pocket guide online on the website. I believe it is on there somewhere. I'm going to have to double check that. I think it's in one of the clinician areas. But if you just do a general search for, like on Google for COPD assessment test, you can definitely find a link to it on there somewhere, whether it's a picture or the test or what have you. Okay, we're getting back down into, yes, we will be able to watch some of this online afterwards. And John gives us a question posted from another group. Are the new portable nebulizers a good thing, and do they work well? Well, a good thing is always somewhat relative. I think anything that improves anything that improves somebody's mobility and allows them to take medications on the go with them, especially if it's something they prefer to take in a nebulizer, I think that's an excellent thing. They do work fairly well. Most of them on the market now, a lot of them are what are called ultrasonic nebulizers, where instead of using the traditional the spray of gas through there, they vibrate a lot faster, and they create a fine mist. I do think that works pretty well. What they have not in their favor is that they tend to be more expensive, and so coverage isn't always so good with those things, and sometimes people have to pay out of pocket. Sometimes you can get them for a fairly reasonable cost, I believe, but again, reasonable is kind of up for interpretation also. If it's something that you are able to obtain, whether it's covered or whether you self-pay for one, then by all means, if you're on a nebulized medication, if you're on a nebulized medication, then yes, by all means, grab one and take it with you. I don't know that it's necessarily necessary to run right out and buy one and switch everything over to a nebulizer, but it's certainly an option for you. One of the key things to remember here, and something we'll again touch on next week, when you have the proper inhaler, and I'm talking about these kind of inhalers, when you have these kind of devices, when you have the kind that fits your abilities and your preferences and all that stuff, you will get the same medication as you would with a nebulizer. For example, a lot of times people will have a rescue metered dose inhaler full of albuterol. 2 puffs of this with the appropriate technique and the appropriate breathing pattern give you the same amount of medication as that whole 5-minute nebulizer treatment in the little saline bullet. The nebulizer, it looks like a lot more because the nebulizer is designed to waste a lot of the product, obviously. And also the nebulizer is much less sensitive to breathing pattern. And so that's why we use it a lot in emergency situations like in the ER or things like that. Because when you are not able to use proper breathing pattern, then it's much better than an inhaler. But these are all things that need to be accounted for when people are talking about what medications they're on. It's an addiction. Probably the smoking. Yes, absolutely. Smoking is, we're finding that a lot of studies are saying it's as addictive as heroin, and quitting has to be looked at as a lifelong chronic disease too. You never are able to give up quitting in most cases. I mean, we all know that, we all hear those stories, know those people who one day decide that they're going to just quit and that was the end of it, and so on and so forth. But they do tend to be the exception of the rule, rather than the rule. Honey helps COPD. I take it most days. Does it help? That's interesting. I have not heard that one before, actually. I can see where I remember back in the day, my mom used to give me tea with honey when I had a sore throat, and so I can see certainly if you have a lot of coughing, it can soothe a lot of that in your throat and your upper airways there. So that certainly makes sense, but that's good to know. Live on oxygen, no heat and cold hurt most people, but honey is great, tastes good, absolutely. It helps me, never wheeze. That's great. It's important to remember that not everybody with COPD, it does wheeze. So if you wheeze, that doesn't mean that you're worse off. If you don't wheeze, that doesn't mean you're weird or you're misdiagnosed or anything like that. We did a talk a couple weeks ago about what does normal look like in COPD, and the fact of the matter is everybody's normal looks different. What's normal for person A is not going to be normal for person B. Person A might live at a place that person B would consider an exacerbation or a flare or what have you. And so it's very important to not get caught up necessarily on what everybody else is doing and feeling like it's great to tell stories. But as we're seeing on the Foundation's website this month, as part of the COPD Story series, everybody's story is a little bit different. And so it's important to not get, if your symptoms aren't exactly like somebody else's, it's important to not get too disappointed by that or depressed or anything like that. So hopefully that can be some encouragement for people out there. Hey, Alan, appreciate the input there. Agree, RTs are needed in primary care settings. We are working on it. Hoping to provide some more evidence by the end of next year, certainly, that we can make a big difference. Here in our clinic, I can tell you that we have presented a poster, and we've had a couple other things. The American Thoracic Society says the minimal important difference in a CAT score is 2 points. And we have consistently demonstrated an improvement of 4 to 5 points within 2 months of somebody seeing their respiratory therapist here in primary care. So we feel it works. We feel that there's very little downside to it, and we feel that it's going to be the future. So those of you out there who are real close with your primary care providers, tell them to drop me a line. I'd like to bend their ear a little bit and try to get some more RTs out there in this setting. Foods that help other people. Certain foods, again, good nutrition. It's important to, everybody's nutritional needs are a little bit different, but as a general rule, relatively low carbs. They don't turn into carbon dioxide. They don't create gas in your stomach that prevents your diaphragm from moving. And high protein. You burn a lot of energy struggling to breathe. And so you build a lot of that back when you have good protein levels. So I feel like I'm suffocating when I get out of breath and panic. How do I stop the panic? It's awful. Absolutely. There is very little worse than not being able to breathe. And so I'll again go back to the whole pursed lip breathing thing. That's usually the first line that I recommend people. because that does a couple of things. First of all, it has a direct physiological impact on the air moving out of your lungs. Helps flush out some of that stale air and helps do a good job of getting fresh air back in. Plus, from a mental aspect, it helps kind of get things back under control. It's kind of a sort of a Zen sort of philosophy thing, but you're a little bit more mindful about your breathing, and you are able to relax. You kind of go to your happy place, so to speak. Those are kind of the first line therapies that you can use. There are some other things like diaphragmatic breathing, where you really kind of reinforce your belly, and you make sure you're kind of breathing deep and low, I guess would be the way to say that. Making sure that you keep your upper chest as open and as wide as possible to help everything expand properly. There are a lot of people who struggle with anxiety with COPD too, and that's okay. It's okay to talk to your provider about a drug that works against anxiety. We see that can be very helpful with a lot of people who struggle with shortness of breath, because it is a terrible sensation, and it makes you not want to do anything because you get concerned. Well, if I get short of breath just walking across the room, how am I supposed to go check the mail or something like that? How am I supposed to shovel my driveway coming up on winter here? How am I supposed to rake the leaves? And so it's important that we work to minimize the root of the anxiety and to improve the breathing and all that kind of stuff. But it's also okay to get some support to lower the overall level itself. So hopefully some of these tips will help with that. Does your oxygen level slowly go down with COPD, and is 93 bad? Well, as Faye mentions, 93 is actually pretty good. There is about much difference between 99% and 91% in oxygen. Unfortunately, once we get under 90, then everything starts kind of going off a cliff. If you really get bored some night and are having trouble falling asleep, look up the oxyhemoglobin dissociation curve, and that'll put you to sleep in about 5 minutes. But suffice it to say, 93 is pretty good. Oxygen levels can slowly decline in COPD as it advances and as everybody gets a little bit older. As everybody gets older, even with perfectly healthy lungs, sometimes we see a decrease in the oxygen level. With COPD, you're a little bit more behind the 8 ball, so you see, you're closer to the danger zone, and the same amount of relative loss puts you into the danger zone. But 93 is doing pretty good right now, and it's just something you're going to want to monitor as time goes on. And when it gets down into that 80 and 89, 90 range, then you're getting close to probably needing some of that supplemental oxygen. And according to Medicare guidelines, once you hit 88 or below, then you really do benefit from it. Athletes don't hit the wall the way we do if we desaturate. That's very true, because athletes don't tend to desaturate. And that's, again, it's not really necessarily trying to compare one group against the other or anything like that. It's just to kind of emphasize the point that oxygen level and shortness of breath are not necessarily tied with each other. Low oxygen can certainly cause shortness of breath, but that's not the only thing that can cause it. So that's very true. Heard that blowing up a balloon helps you clear out your lungs. Is that true, or does it hurt you? There's debate about that. Balloon is probably not the thing that I would use, that I would recommend. I don't know that we really have any kind of studies that show it or anything like that. There are certain things that talk about resistance and expiratory resistance training and that sort of thing. What I find is, like I said, the purslet breathing can work just as well. With a balloon, you do have the risk that if it suddenly deflates and pushes all that back into your lungs suddenly, that can do some bad things, especially if you have very severe emphysema, things of that nature. So it's not something that I would necessarily recommend. But especially, I think you can do just as well with some of the things that don't require props. So, Let's see, high heart rate, covered blowing up the balloons. Harmonica and a tonette by the chair. I'm not sure exactly what the tonette is, but harmonicas are fantastic. Something that we'll be talking about in a couple weeks when we talk about breathing patterns is the COPD Foundation, again, has a program called Harmonicas for Health, where I was fortunate enough to participate in a session with Stephanie Williams from the foundation, who taught us how to play Twinkle Twinkle Little Star on the harmonica. This summer at COPD 10, I had the great honor of participating with a local Harmonicas for Health group in a tribute to the late founder of the COPD Foundation, John Walsh. We played Amazing Grace, which was an incredible moment at the conference. I was extremely honored, very grateful for the opportunity to do that. So harmonicas definitely do help because they kind of do a lot of the same things that we're talking about. They give you you have a little bit of expiratory resistance, and you have to control that breathing pattern. So they can be very effective, and so that's a great thing to keep by your chair. They're not very expensive, and they can do wonders for you, whether there's anybody there to hear you or not. Had that, but it was one time. If you get it set up, we'll bring it on. Never happened again. Not sure, Faye. Maybe you can remind me what we're talking about there as far as it never happening again. Mucinex is a thing called a mucolytic, or it helps bring up some of that mucus, helps thin out some of that mucus. Can work for a lot of people if that is your issue. A lot of people don't have the excess mucus, and so it's going to not really help them very much. So it really depends on your particular symptoms, your particular set of symptoms. But it can be very helpful, and it's usually available in a store brand, so it can usually be pretty cheap too. It can be a fairly cheap and effective solution for a lot of people, especially on bad symptom days. Do I like spacers for albuterol? I absolutely love spacers for albuterol. For those who might not be familiar, a spacer is this. What we see with these, and we'll again talk about these a little bit more in depth next week, these allow a little bit better time to coordinate between puffing the inhaler and breathing it in. So they help improve your technique. They help improve the particle deposition, so to speak, the amount of medication that's getting into your lungs. Sometimes they're a little bit bulky, and sometimes they're a little bit expensive. So we are able to offer a solution here in our clinic called a mini spacer or an inflow cone. And they work very well too. They're a little bit more portable, and they're a little bit cheaper. So definitely I encourage everybody to use a spacer as much as they can, and with every inhalation is ideal, with the meter dose inhalers, not the dry powder inhalers. So definitely like the spacers. Balloons help get the trapped air out if you have emphysema. They can, again, I look for pursed breathing and stuff like that a little bit more effectively. If you do have emphysema, you tend to be in that little bit higher risk for what we call having a bleb rupture, or a big spot in your alveoli. If that were to suddenly deflate, you might see that kind of issue. Personally, I'm the kind of guy that, for the most part, if something works for you, I'm not going to tell you, unless it's very high risk, which I don't personally believe the balloons are, I'm not going to tell you to stop doing it. But it's not something that I would have as a primary recommendation. Can you discuss target heart rate zone when exercising? Gyms show 200 less your age. My doctor has me at 200 less your age. Wants a safety buffer, but see many posts with heart rates way up there in the 160s, 170s, 220, yes. Generally speaking, that's the acceptable heart rate range for the 220 minus your age. And so for a 60-year-old person who's in reasonably good health, that would be 220 minus 60 is 160. So that's probably a fairly reasonable range. With lung disease, it can be a little bit trickier. You might want to have a little bit of a buffer and target a little bit lower. But again, it really kind of depends on your individual capabilities, how well, if you're in shape or not, if you've gone through pulmonary rehab. I think it's reasonable to target in the anywhere from 140 to 160, just depending on what some of your goals are and that sort of thing. Also, it's gonna again, anytime you undertake an exercise regimen, you should clear it with your provider first. But it's going to strongly depend on your goals and your functional capacity. I don't really have a lot of information about how much per day is therapeutic, so can't answer that one, unfortunately. Dr. Ballas, no, I did not. I don't know that particular physician. I mentioned Dr. Type earlier, but I do not know Dr. Ballas. Hopefully, you're getting very good care from her up there in Portland. Rather than Mucinex, use NAC. Google it, available at health food stores and Amazon. What is NAC? Well, let's talk about that. NAC is N-acetylcysteine, which is considered to be an anti-inflammatory medication and mucolytic, a mucus thinner. It does seem to work fairly well. Traditionally, we've used it in a nebulizer. We don't like to do that because it smells like rotten eggs, and it's kind of horrible. But there is a pill form of it, or a capsule form, that you can take that is often available wherever you get supplements. And there is some evidence that says it does help. There's not a lot right now just because, frankly, there hasn't been a lot of research done in it. But it is one of those things that I am personally kind of intrigued by and I think has a lot of potential. So I don't know that I would say rather than, but it's certainly another option. Current guides for prednisone dosage and duration for COPD flares. The less and the fastest, the better. We're seeing a lot of like the 5-day burst. I'm trying to remember exactly what the milligrams are off the top of my head. I usually have a nice little reference for that, but usually like to try to keep that in the 5-day burst instead of doing the longer tapers. We're seeing it working pretty well as the longer tapers, and trying to reduce your exposure to steroids, which is always a good thing. So trying to keep it quick and fast, basically. I don't recall the exact number off the top of my head. I apologize for that, but I don't want to give you bad information. I do know it's a 5-day burst in many cases. I don't know if I'm going to be going to Carnegie Hall anytime soon, but I do encourage the harmonicas as much as possible. And yes, Pam, I thank you for firing that up there. Much better things to use than balloons. And again, you can have that rupture in your lungs. There's again, if it's been safe for you and you don't have the risk factors, that's fine. But a lot of people don't know that they have the risk factors, and I also tend to be better safe than sorry. So again, not something I would recommend. Tonette like a flute. All right, thank you. Appreciate that. We're going to take a couple of these questions here, and then we're going to start wrapping things up. Paramedics refused to transfer my brother. He's on O2. His pulse ox was 84 with O2. What number do they look for? Paramedics said 80s are normal range for COPD patient. That paramedic was absolutely wrong. 88% or less is dangerous for anybody, if you're on oxygen and 88% or less, you need more oxygen. You don't need to get blown off by the paramedic. So that was absolutely a disservice to your brother, and they should not have done that. And that's a safety and clinical standard violation. I know maybe that sounds harsh, but that paramedic should absolutely be written up for that if that's how that went down. 80s are not a normal range for anybody, whether you have COPD or not. 89 maybe, but certainly not any lower than that. Why do you have pain in your lungs and in your back? Because that COPD can cause pain. It can. Again, in some forms of COPD, you have the lungs get bigger as they lose some of that alveoli area inside. So they need to get bigger in order to get the air, to move the air effectively. And so that changes your body shape, and that changes your posture, and that causes all kinds of issues with your joints. Including the joints between your ribs and your joints in your spine and all that stuff. So it can absolutely cause some pain. In addition, a lot of people with COPD cough a lot, and you use a lot of muscles when you cough, and it's very easy to strain muscles and to mess up again, mess up the joints and that sort of thing. And so it can be very painful. It can cause a lot of pain for various ways. So again, maybe that's not necessarily an answer about why, but it does happen, and it can definitely be related. And so we'll end on this note from Cecilia here. Follow your doc's orders. That is a very good recommendation for everybody. Again, these programs are great. Anything we do online is great. But your provider is the one that is seeing you and knows the details of your case. My goal with these kind of presentations is to give you the tools and the knowledge you need to ask the right questions and to push for the right care. Hopefully that these tidbits and these questions will put you in that right direction, and give you the tools that you need to be an engaged, informed person in your care. All right, we'll do two more here real quick, and then we'll call it a day. First off, saw a comment about liquid acetylcysteine that actually traditionally has been given as a nebulizer, so that's not really all that far off base. But it has also been given orally, where you swallow it, for Tylenol overdoses. That is very true. Liquid oxygen drops used as a supplement, drops in water, absolutely useless. Not going to do any good at all. It'll diffuse into the water, and your digestive system is completely isolated from your respiratory system, which is, if you've ever aspirated water or had something go down the wrong pipe, you are well aware of that. So oxygen drops are just another thing that people sell you to take your money. I think I saw a thing about ozone therapy. Some seems to have scrolled away now, but I did see somebody mention about, there it is, ozone treatment. Ozone treatment can be very dangerous. This is something we talked about in our COPD Navigator group recently. Ozone is an irritant, and that's why we see those ozone action days on TV from time to time, especially in the summertime. So exposure to ozone can be very dangerous for people who already have irritated lungs. It can cause additional inflammation. It can cause a lot of respiratory symptoms. So I would not at all recommend somebody participate in any kind of ozone therapy. I know there are certain air purifiers that use ozone to purify the air. Sorry about that. I would avoid those whenever possible. I would avoid cleaning products for ozone, and just stay away from it. It's not going to help. So that is today's session. I invite everybody to come join our group if you are so motivated. We do these things. We're going to be doing these through the foundation every Friday at 1 p.m. COPD Navigator Live. Through the month of November. Outside of the month of November, we do them in our group, COPD Navigator, here on Facebook, facebook.com/group/COPD Navigator. This video should be available through the Foundation's webpage, or their Facebook page. And we'll also be posting a link to the YouTube version for people who couldn't join in today. They'll be up probably over the weekend and possibly early next week, just depending on how busy my weekend is. And we'll be doing this again next Friday, 1 p.m., where we'll be talking about medications, and we'll also be talking about whatever happens in the world of COPD between now and then. And, of course, we'll be taking your questions. So until then, please take care of yourselves, take care of each other, and have a breathe easy week.